Proceed.
Good evening, everyone. Welcome to the centenary celebration of the Department of Mechanical Engineering, IIEST Shibpur. We are here for the 22nd lecture under the centenary lecture series to be delivered by our honorable alumnus, Apurba Mukherjee, on the topic Time for New Approach to Early Detection of Breast Cancer, Introductory Technologies in the Molecular Liquid Biopsy Age. The session will be chaired by Apurba Mukherjee, who is Associate Professor of Practice, University of Texas, Rio Grande Valley, USA. Over to you, sir.
Kamunga, please.
Good evening, good morning, whatever may be. I will start my introduction for our dear beloved dadas and junior brothers and distinguished Centenary Celebration Committee members. It is my great pleasure to introduce Apurva, Dr. Apurba Mukherjee, who did his undergraduate from Jadavpur University in 1963, and he became our alum in 1965 during his MTech in in B College. 1976, he got his PhD from IIT Delhi, and he came to USA in the UC Berkeley Material Science Department, and from there he started his professional journey. He started his career in GE nuclear reactor, and from there he moved to high-speed image transmission through fiber optics. That is where he got interested in entrepreneurship and innovation. He was one of the pioneers to develop high-resolution image transmission that led to medical devices called microendoscopy that basically allows to image the milk duct in woman's breast so that they can identify the changing shapes and figures of cells. That led to the early detection of potential cell deformation that can lead to formation of breast cancer. That was his innovation. And he did his patent and FDA approval pretty soon, and using that, he started his company. It is very interesting to note that starting as a mechanical engineer, he moved to material science and then to medical device. That is his trailblazing achievement, but that's not enough. He has also a soft side. He was the first person to bring the biggest Bengali adda in North America from East Coast to the West Coast about 40 years back. Thinking about both the hard skill and soft skill, Apurva did an amazing stuff, and he's a true role model. Once again, it is my pleasure to introduce Dr. Apurba Mukherjee, an inventor, entrepreneur, pioneer, all packed in one showcase, mechanical engineer of IIST Shibpur. We are very proud of. Now, up to Apurva to get started and tell his journey and story. Apurva, please start.
Okay. Thank you, Professor Sharkar and all the audience. I'm going to give you a topic today that with the advancement of various other parts of science, we have many new things coming up in cancer detection. And this one I'll go through today, and then we'll ask for questions. Now, time for the new approach to breast cancer screening for early detection of breast cancer, intraductal technologies in molecular liquid biopsy. So, my another presenter is Professor William C. Dooley, but he's in clinical and he couldn't come today. The statement of the problem is screening for breast cancer at high-risk lesions had several decades relied upon mammography. With the advantage and science of molecular pathology coming up, the liquid biopsy in oncology, we have failed to engage other techniques to address the breast cancer detection at very early stage. New submillimeter endoscope systems are now available and are in the use in some countries like USA, Germany, and England. Studies of ductal lavage and ductoscopy sampling have shown the tremendous power of molecular approaches to indicate breast cancer at high-risk patients, all sizes smaller than traditional breast mammogram imaging. These may provide the next major revolution and early detection of breast cancer. Now I'll say what we have. About the Saga Medical LLC, we develop, manufacture, sell flexible microendoscope for intraductal imaging, which is ductoscopy and other medical applications. The Saga Medical microendoscope is used to investigate nipple discharge and allows for a more targeted and accurate approach in locating abnormal ductal lesions for excision and biopsy. Further, this microendoscope is capable of detecting precancerous cells in milk ducts 10 to 15 years before the mammogram. The Saga Medical microendoscope system is FDA approved, made in USA, and it has a microendoscope, USB-based camera system, portable, fiber optic LED light source, additional monitor for viewing, and the both the USB camera and the LED light source, they work on USB port, so 120 to 240 volt can be used, 50, 60 cycles, anywhere in the world it can be used. And this is capable of viewing, recording still images and video clips. And this is how it looks, this microendoscope. Unfortunately, I couldn't couple it. Yes, this one. So this one, you see the light source. In the light source, this is the only scope in the world which I have designed. It has got two light sources can be attached at the two ends, and that's how the fibers are distributed. And you can put one in LED, one in xenon, or you can keep the both of them on and mix the light. So half xenon, half LED, and see where you get the best contrast and for viewing and recording the abnormal cells. The next one, this is Professor William Dooley. He is doing the ductoscope on a lady. In Los Angeles, about 100 breast surgeons came all over the world, and our scope was selected for demonstration. So one lady says, okay, you can do the ductoscopy on me. So we give the doctor gave a local anesthesia and some cream and put the ductoscope inside the nipple, and people are asking how you feel. They say, I don't feel much, but I feel some pressure, but no pain. And that's how it can be done. So this procedure can be done either in the office environment, in a doctor's office, or in a hospital environment with all accessories are available. But it can be done in the doctor's office also. Now, this is most useful in screening high-risk patients. The high-risk patients, we mean that in normal sense, if their blood relative, maybe mother, sister, or any blood relative has breast cancer, then the risk is higher. Normally, in the United States, 1 out of 8 girls breast cancer in their lifetime. But if they have any blood relative having breast cancer, then this goes up to 1:3. So 1:3 is very high. So high risk is a simple test, and if it is screened for, it is maybe for few years it will be valid, but for high risk screening is very, very effective, especially for this doctoscope. Now, typical statistics in the United States, and this I said 1:8, that is not only USA, but mostly all developed countries, including Europe and other places. Now I'll give you some highlights of how the scope is in the United States. The breast cancer. Every year, 200,000 or more new cases of breast cancer are diagnosed in US. Every year, 200,000 new cases. Every year, 40,000 or more women die out of breast cancer. And at this time, there are about 3 million women are living with USA with breast cancer. They have breast cancer, it has been cured, but they are living with it, and so that make sure that it never comes up again. And the recovery rate is very 89% is the recovery rate. So precancerous cells, if we can detect it, then many places it will, the breast cancer will never come back or it will never happen. One more thing. So this is the US government data that 1/8 of 8 girls gets breast cancer in their lifetime, and 2.7 million is the people who are living with breast cancer. And 40,000 is the people who die every year in breast cancer. Now, this is a pattern which shows that how the 0.7 millimeter diameter, we are putting 10,000 optical fibers, and then you have the light source, 2 light sources can be put in, and also you can put in the laser light in certain special cases. And this is the camera. The camera is a universal C-mount. So the lens system of the scope, this one can be fitted into the universal C-mount, and you can record the video. Normally how it is done that we put in the scope inside the breast, and turn on the video. So it continuously makes the video and puts it in a special format in the computer, and any doctor can read it and send it by internet to any other doctors, and get consultations can be done. And typically the accessory system looks like this, that you have a monitor, you have the light source, you have the camera, and you have some other auxiliary sources. And this is typically the anatomy of the breast, and how this one looks like. This is the scope. This goes inside the duct. And this is in a hospital environment, this is how it is inserted. And this is the which water is put in first to inflate the ducts, and then we put the microendoscope. And this is the things we need to collect the ductal fluid. Now, any questions I would like to have, I'm very happy to answer. And one more thing I would like to add that what happens in breast cancer is usually if it is not detected early, then it can go to one of the four places. Common is it can go to the brain, it can go to liver, it can go to lung, and can start there. If you go to the lymph node, and then you can start many places. But if you can detect it early, then those going to other places of the body will not happen.
Thank you. Thank you, Apurba, for the wonderful presentation. Let me break the ice. Let me put the whole thing what is said in layman's language because I know nothing about this stuff. Okay, so what I'm trying to understand is that your innovation or elegance of your innovation is that you looked into the actual cell using high transmission fiber optics where you can create the image and then bring it back. So all you did is really magnify the whole process. So by using fiber optic, we're talking about 0.7 millimeter means it is about 700 micron, right? 700 micron, you are talking.
No. I would like to correct you. It is not 700 micron. It is 700 pixels we are doing. It is the actual fiber
Okay.
with the core and cladding. So we have 10,000 fibers done in a very special way. They are built so they will fit in that 0.7 millimeter.
Correct. So that really means we are talking about the nanoscale fiber optics.
Exactly.
And now we are talking about those, every fiber optic creating a pixel or bringing back some image so that we can see what is going in the micro or even submicron level or in other cell level.
Exactly.
The reason is that what we are doing is that more again, coming back to his layman's language, you take the nipple and put some water into it because when the milk comes out, it's an opaque liquid, so you cannot see anything. So to inflate the nipple, you are adding some water. And then under the contrast of the water, you can see how the cells look like. If they're a normal cell or abnormal cell. That's the way we find it out. True or false?
Yes, the water we put in because in ordinarily these ducts are collapsed. So if the endoscope has to go in, then it can scratch and it will not be able to move properly. And that's how we change the refractive index that the light is going through the water. The water supply will be there all the time when the endoscope is inside the duct.
Yes, you are absolutely right. That means the water has got multiple effects. One is that to dilate the ducts so that it is larger. Number two, it creates a contrast so that you can take image, right?
Yes.
Okay, and now under this dilated contrast media, now you can take the pictures of images of the cells and now compare with your standard cell, whether they're normal cell or not normal cell or abnormal cell. That's how we decide whether there is a potential for risk of breast cancer. Is it true?
It's true, and I will give you the what is normally done. Say in every hospital, the protocol is first to do the mammogram. The mammogram can detect the tumors. It cannot detect the cells. The minimum size it can detect is half centimeter or around that size, the tumor, or they see some black spots. But we can see with this liquid biopsy, the material we get out of the duct in a fraction of a millimeter, we can detect.
You are absolutely right because I have some experience with my wife. she had a lesion in her right breast about 15 years back. And we got scared whether that was really a indication of breast cancer or not. It turned out it was a false negative. Okay. So this is, I think your technology comes into play. And it took mammogram for year after year of taking it and comparing the images and see whether it is a good or normal cell or it's a normal adjustment, natural adjustment in the lesion, or it is something more or is expanding. Over the years, we found out no, it's not. It's normal. So we are now happy. So that's exactly the your type of intervention will be very, very helpful. Only concern or question I have got for you is that you are using water to dilate and then try to get images. Is there any potential to use a contrast agent into the liquid or fluid, rather water, so that you can get better images, or it is not needed?
Yes, certainly. Certainly, if you think that the contrast you require is not there, you can add any dye which is completely safe and can be used for the endoscope. Normally, we have not seen that yet, but let me tell you one more thing. The difference between the mammogram and the ductoscope. The mammogram sees the half centimeter or less the tumor, and we see the submillimeter scope when the abnormal cells are the size of fraction of a millimeter. So even if the mammogram is negative, that doesn't mean that the cells are not there, because they have not found the tumor and come up to a larger size, which can be detected by mammogram.
Actually, this is an excellent point, and I agree with you. Mammogram is that really you are talking about a millimeter scale. You are talking about now scale. At least it has to be several millimeter to be detected by mammogram. Whereas your technology is apparently can go or detect sub-millimeter scale. So basically, we are talking about one order of magnitude difference. So
Exactly, even more.
maybe more, at least. So what is happening that you can probably detect the potential of uh, breast cancer years ahead. And so far I know is that the biggest advantage of cancer is that if we can detect earlier, there are lots of options.
Exactly, you're very, very right.
The further you go away from your detection, it takes years. The cancer spreads its tentacles all over the body. It goes from not only from breast, it can go anywhere.
Exactly.
I
And
have
then it may not be operable anymore.
exactly
It may not be treatable. If it goes to the brain and it is in a long period, it may not be treatable anymore.
exactly.
And one more thing I would like to discuss, what is the advantage of our system is that, say, in the United States, Germany, France, all the Western world, they have the access to mammogram. But suppose in India, we make it the total cost of the equipment, the procedure, maybe 100, 200 rupees. And it is fully portable. You don't need the electricity. You just need the charged batteries. And you don't need the mammogram machines. That is a very, very expensive. So compared to mammogram machines, these may be total system, maybe $2,000. And it will last for a long, long time. And the per procedure cost is almost nothing, because you take the introducer and dilator, it can be autoclaved. And in India, I talked to the breast surgeon, they say anything you can autoclave, you don't need FDA approval.
Kamal,
That part-
Biman has a question.
Oh, go
Biman has a
ahead.
question.
Actually, I was waiting for somebody to pick up. Okay, please go ahead.
Kamal, no question. What I was suggesting, if it is okay with you to let Dr. Mukherjee finish his presentation, then we go into the discussion mode. Not
I
to
think
interrupt the flow, but to enrich the content with your valued input.
his Apurba, do you have anything else in terms of presentation? Go ahead. I thought it is over.
No, presentation is over. All questions and answers if you have. And if you have any specific questions for a doctor, then I'll give it to me, send an email to me, or give it to Shudip, Professor Shudip Ghosh, and he can send it to me. I'll talk to Professor Dooley and give you the answer.
Okay.
Engineering wise, I can answer the questions.
Well, Apurba, then my name is Biman Ghosh. Let me go ahead. I just have one comment, not related with your lecture, but in terms of inspiring the faculty member and research community in IIEST. I really don't know whether we have this kind of interdisciplinary research in IIEST. So is there any specific like suggestion or guidance from your side that you can mentor a few of our younger faculty members in terms of their research interest if someone is trying to like venture out in this area? Because I think that is one of the area you could be a big help and big influence.
Well, I would like to give you an example. Sometimes back I gave a lecture and there was some people who were on the electronic side, and they said that, we have companies are moving here and there, but in the Silicon Valley's companies will never move. No matter how much incentive you give, no state can take them from Silicon Valley, California. And then one stood up and said, do you know why? Because of Stanford University. All the technologies originate in Stanford. They will not go to Boston. They will not go to Maryland. No matter how much you try to, give them incentive. So IIST, maybe the IIEST, maybe the center of technology, which will bring the technology in say West Bengal or in other areas. And whatever we can do, definitely, I would be very, very happy to do that.
There must be some takers who would like to collaborate with your teams, know more, and recreate the facilities. I'm not sure.
I'll be very happy to discuss that. Next month, I'll be visiting IIEST. So maybe I can contact you at that time.
Yes, do contact us.
I'll definitely contact Professor Ghosh, Shreep Ghosh, and we can discuss and see if there is anything possible.
We have a biomedical school. A few scholars are also there. In fact, I requested one of the faculty members, Professor Rai Chaudhuri is here. I'm not sure whether he has any queries or not, but yes, we do have a research school here who are working on some other issues. May not be into this kind of investigations, but maybe some scholars will be taking interest, or maybe
Yes,
some.
Definitely. I would like to bring a scope to show you sometime in the middle of July. You are the only one Shibpur has it. I asked Jalpa University, I visited and gave a lecture last 2 years back. And they said they don't have any health science department. Only you have a Kharagpur IIT Health, to the best of my knowledge.
Well, any queries from our scholars? Sir,
I think you are the center of all smart and intelligent people. So you can be the center of many technologies which can flourish.
Yes.
There are any other questions, comments from the students? I think I'm hoping the students will jump. Oh, Amitabh, go ahead. Any other question from anyone? The floor is open.
Sir, what is the success rate
So I think
in detection?
you could also highlight something about the kind of future developments you are planning. Then maybe some of the
So
students or
I would like to give you a little bit on this for the future development we are doing. And in your IIEST newsletter, which came out, I think, last year or so, not last, a few months back, I wrote an article. Now, one of the future things which is going to come out during the next 18 months or 24 months, that the intraductal fluid which we get, we have to, Professor Sarkar said, should be contrast, and we have to examine it, these are cancerous or not. But suppose you said no human being is needed. We see the DNA sequencing of these intraductal cells, and you give it a 40 microliter or so to the DNA machine, it will check the library and say it is, yes, it is cancerous, or it will come out and say it's not cancerous. So that would be the ideal thing in future. During the next 2-3 years, I think it will. I talked to the DNA sequencing people here. The equipment cost about $20,000, the basic equipment, but the libraries are not there yet. That what this sequence means what?
Looks like there's a question. Go ahead. Apurba, why can you talk about your contribution to AIMS and other places where you contributed your equipment and they did some studies? Why can you talk about that? That I'm talking about the collaboration you did with many Indian hospitals. Please talk about that.
Sure. See, I think the best way would be to not a very large investment to buy the components, because these are component based and endoscope, and you buy the components, assemble, test, and you can sell. So if someone is interested, say IIEST says that we will provide this laboratory. So the laboratory, the people will be trained, and when I go there, I'll discuss in details also with the physical models that if you develop the technology and have the people around, maybe in Shibpur in other areas, that who says, okay, I will invest 1 or 2 crores and develop the technology, and I'll give it to the hospitals. Now in the hospitals, in US, there is one problem we face, that we cannot sterilize it all the time. And the hospital does the sterilization, and the hospital has many different sterilization systems, which mostly the scopes can be sterilized. And in USA, we do not autoclave the introducer and dilator. So that you have to try and get a new one. So if we can have that facility that you can autoclave, and autoclave is needed, I think most of the hospitals or the equipment suppliers, they have the autoclaves. Then you can autoclave the system and you can use it. You need the biggest problem is to teach the doctor how to use it. That is a very important thing the IIEST can do. Then MBBS doctor comes out, and in future, I think I just said that the DNA sequencing, if you can do the DNA sequencing, then you don't need a doctor even. A senior trained nurse can get the ductal fluid out and do the DNA sequencing.
Sir, what is the success rate of detection using this ductoscopy?
What is the question?
What is the success rate? Means if you have taken several, or you have taken runs or samples from different sources, in how many cases could you detect rightly? Or what is the chances of
Okay.
missing? Because you are basically investigating a region which is at the sub-millimeter region. So, I mean, how do you pinpoint the area where you should find to locate that cancerous cell?
No, you do not look at the cancerous cell. It is
The fluid will be
in the system. It is in the duct now, and it attaches to the lining of the duct.
Achha.
So we do not see in the basic equipment. We do not take the cells out. What we do is we see if these cells are present or not. If there are a lot of experiments have been done that all breast cancer starts within 2 centimeters from the tip of the nipple.
Achha.
So 99% breast cancer starts within 2 centimeters from the tip of the nipple. In the duct, it stays inside the duct, the layer. So we go there, take the photograph. And we are not taking them out in the first phase to do any further examination. In most cases, that is good enough. You take the photograph, you say we see they are present, so you do the conventional treatment.
Apurba, I will follow up on Ashok's question. Basically, what we are talking about the efficacy of the system. What we are doing, if I understood you right, you took an image, and that image has to be interpreted. That whether it's a normal cell or a not a normal cell. It's like taking an image from different angle, different length, different depth. So you get different same thing.
No, Professor Sarkar, no different angle, no different shape, nothing. We
No,
put directly at 90 degrees and see if the internal layer of the duct has got any abnormal cells, period.
I understand that. My question is that then how we know looking at the image that this image is a false positive or false negative? Basically, the gold standard on any cancer detection is biopsy, right? So biopsy will tell you that whether it's a cancerous cell or not. Now the question what Ashok is asking, and I have the same question, is that, okay, I took some 100 images and 100 situations and say, okay, out of 80 of them, we correctly identified that is a cancerous cells that was proved in different methodologies. Now, rest 20, there could be 10 of them could be false positive. That means it is not cancerous, but your system or your interpretation said it is positive. Or it could be false negative. That means your system or image interpretation says that there is no cancerous cell, but it turned out that it was cancerous cell. So these are the numbers statistical numbers we are looking for. What is the efficacy of the system? How many standard cases you have imagined and standardized cases and say, okay, out of that, we are correct 90% of the time, 95% of the time, 98% of the time, and
That's
some
what
of
I
them
have been
are
asking.
false positive cancer. Have we done that studies?
No, we have not done that way. What we have done, say there is 100 patients for having some problem with the breast, or we have decided for other reasons like their blood relatives have got breast cancer. So at that time, we see the 30 or 40 girls or women, and we say that these are the positive, from the picture we say positive, nothing else. They may be the candidate for breast cancer detection early. We just say that, say out of 100, we say 10 or 8 people have to be further investigated. That is, you have to take some duct out, do the liquid biopsy, and do the confirmatory test, whether it is cancer or not. So if you take at random, say 100 girls or say 100 women, you will find average 8 of them are positive. And when this is positive, we may get 10. It looks like positive, 20 looks like positive. But actually, after the biopsy, maybe you will find that maybe 7 or 8 are 5 have got the actual breast cancer cells. So that will be done after the biopsy.
So basically, it looks like you have not done, there's not enough data to do detailed statistical analysis with any level of confidence that will say, okay, our system is 98% accurate with, say, 90% confidence.
No,
So, of course, we need lots of data and a lot of analysis. I don't know whether you have
but
done it.
we are saying that this looks like positive. We have to do the biopsy. It's a candidate for biopsy to determine if it is yes or not.
And
Like
then,
I say, like what you are saying, it is done in the mammogram because you are seeing the pictures, the dots. So they are negative. It may be falsely negative, falsely positive, or because they have not done the biopsy yet, they just saw the picture. But we don't have that. We are not taking the at random pictures. We are taking very specific picture. And we are saying now they have to do the biopsy to determine if these are cancerous or not.
Okay,
got
but this
it.
is not really a
With the
confirmatory
advance
one.
of the liquid biopsy, you don't have to take any cell. The fracture of cells you are getting from the duct, that can be used for the liquid biopsy to determine if these are cancerous or not.
And probably we'll have to wait for another 8 to 10 years to find it out whether she developed really the breast cancer or not. It may happen, may not happen. Correct?
That has to be in future will be done with the more advance of liquid biopsy. People will be more and more. It is just growing. This subject introductory is not being used everywhere. Only in we find about 6 hospitals in US that regularly they used to buy from us.
When this it was approved by FDA 2012, right? When it was
FDA approval, yes, I think 12 or 13, something like that.
okay. So okay, and have we sold or how many units you have sold so far?
How many?
Units you have sold
Hospital
or
fine takers
hospital
in
sales?
What image?
Your system is your endoscopy or rather doctoscopy, that unit what you are selling from Shaggy lab, how many have been really in use right now? About 50, 100?
Yes, it has been used about maybe 200. 200 scopes we have sold, and they have
you are
used
now
it on
commercially offering it,
patients
right?
and sterilized and used it again. So about 200, only in US. We didn't sell outside US.
Yes, okay.
Good enough.
The other question actually I have got regarding sterilization. That is an interesting question. I don't know who asked it. Autoclave is the only way to sterilize it or no?
Well, autoclave is not for the scope. It cannot be used on the scope. Scopes cannot use the autoclave. Scope
Correct.
use only the sterilization systems which are used for other endoscopes of fiber optics. Just like say colorectal, or there are many scopes are used. And those scopes are used using 2 of the methods usually in American hospitals. One is STERIS, STERIS. One is STERRAAD, STERRAD. And both the systems can be used on the scope. Autoclave is only for the introducer and the which goes inside the stainless steel tube.
Correct.
That can be autoclaved, not the scope.
I know it because there were plastic parts or there are other things. There are electronic.
It is all fiber, it will melt.
Yes.
This is glass. Glass you cannot autoclave.
Yes. Okay, that was the question. Okay. Any other question from anybody? I think I'm taking too much of time. Is there anybody, any question?
No, Kamala, you are actually like inspiring valid questions. That's too good, too good. I'm glad you are sessioning the chair, and Sudeep and Vidyut, thank you very much for bringing Kamala in the equation to add more value to Apurva's content. Apurva, like just from a different aspect, I understand that you are basically going after these biomarkers or leading indicators for which further study needs to be continued. So what are the competing methods, especially in terms of differentiating this? I know you covered that during your lecture, but what is the most significant aspect of this technique that differentiates this technique from other techniques as a leading indicator and going after any special cause that happens with respect to our changes in biomarkers or blood chemistry?
I do not know any biomarker for the detection of cancer. See, detection of cancer, the gold standard is a mammogram.
Okay.
In America, as soon as someone is 50 years, the hospital will start calling you. We are scheduled. You come, because they have to come, because that's all the budget is done. There's so many women are here. You have to get them the your mammogram. Then once the mammogram is done, then they will do all the markers. They'll do the surgery, and there is a protocol. Everything has to be done. But this is more like some people are in the hospital, a very, very pre-cancerous stage. Then the doctor can use it. I have seen in one hospital in Baltimore, Mercy System, I visited there a few times, and they themselves bought about maybe 100 scope from us. They have 4 stations, 4 girls are coming, and 4 biopsy doing at the same time. And it is continuing almost on a daily basis. So it is the doctor to see that if this patient is, we can do it seems, especially the relatives. See, if the mother has got cancer, all the daughters may have. So for them, they would like to use this technology, intraocular technology, to see if they are candidate for further investigation.
Got it. And the follow-up question might be specifically for US-based audience. How the insurance business is covering this kind of test? Are they very open to it, like the way mammograms are recommended, or like for male?
Well, the answer is that they are aggressive. So in America, everybody has got access to mammogram. And if somebody is 50 years or 55, hospital goes, it call you 100 times to go there and test it. If you don't do it, then where is the revenue will come from?
Okay.
They are aggressive to take you to the hospital, and because all the costs are paid by the federal government. You don't, the patient doesn't pay anything. Some copay is there, maybe.
Got
So
it. And
they are very aggressive. They want to get all the candidates.
So since Kamala mentioned about your work with AIIMS in New Delhi, how are you popularizing or familiarizing this technique for people in India?
Well, this is a very golden technology for India, because in India, most of the people do not have access to mammogram. When I gave a lecture in Jalapur University the last time, then 2 ladies came to me and they say, we have 12-year-old and another 18-year-old girls. We want to know that if they are this cancer positive or not. And the hospital doesn't have the equipment to do it. And mammogram will be negative most of the time. So the only way you can have the introductory technology to see if precancerous cells are there or not.
That is perhaps the winning edge for this technology.
Yes.
Detect,
See, if you have done the mammogram, some tumor is there. They cannot detect the cells. It's not at the cellular level. No mammogram in the world. We are detecting at the cellular level, which is a fraction of a millimeter.